As the data show the pivotal role of the social determinants of health in these disparities, it is important that we as nurses remember the people we encounter are much more than what we see presented before us. They bring their cultural and religious beliefs, centuries of historical trauma and mistreatment, and other factors. With nursing's emphasis on holistic care, it is critical that we take this information into account when engaging different populations. Before we get into what nurses can do, let's lay out what is counterproductive and should not be done. First, do not focus on cultural competence. It is impossible to become competent in someone else's culture. When we learn things about individuals, we don't want to take that and then blanketly apply it to other people and across populations. Instead, let's make it a point to treat each person as an individual. Talk to them, find out from them what is important, such as their spiritual beliefs, healthcare practices, and even their perceptions of healthcare and providers. Second, do not assume that the statistics reflect poor individual behavior and choices. Yes, there are some individuals who are engaging in behaviors that increase their risk, such as not social distancing. However, as Dr. Sorrell pointed out, some of that is not by choice, and it's driven by broader social and structural issues, such as their living situation, work as an essential employee, and even care for loved ones. So instead, let's focus to gain a better understanding of the why behind what people are doing and why they are doing it so that we can help mitigate their risk. And lastly, we do not want to make assumptions about someone's health behaviors, or their merit to be healthy or live based on their race or other attributes. It is so unfortunate to still have to say it in 2020, but every Black person does not have high blood pressure, and every Black person with high blood pressure does not eat salty or fried foods. And so even if you have seen something 1,000 times, leave room for time number 1,001 to be a different experience. And how do we do this? We engage each person with dignity and respect, asking them relevant questions and then being attentive to their responses. Many of the health conditions that we see are related to chronic stress, which leads to prolonged activation of the body's stress response. And when we understand this, we can help people modify their stressors as well as the physiological responses that they have to them, instead of us adding to that load with our microaggressions and biases. Now that we know what not to do, what can we do? The data show the disparities, but they don't help us understand how we got here. If we look at other health concerns from years past, we see that there are 3 core root problems that drive the unfair and unjust differences we see in coronavirus morbidity and mortality. From our families of origin and experiences in the world, we all have attitudes that consciously and unconsciously shape our understanding, actions, and decisions. Even for those with the best hearts and intentions, implicit biases are activated involuntarily without our awareness or intentional control. And while we are not initially aware of them, they still substantially affect how we interact with others, as well as how we deliver our nursing care. The good news, though, is that our implicit biases can be changed. We can work to unlearn detrimental ways of thinking and de-bias our perception of others. This is particularly important when we think about the ways that race dominates our interactions with others. And contrary to historically held beliefs, race is not biological. It is a social construct that was originally devised to give and withhold power. Racism is a system of oppression based on race, which operates through not only individual words and actions, but also larger systems and structures, including our beloved healthcare system. And when that happens, people are aware of the ways that they use their stereotypes and beliefs to discriminate against others. This includes denial of diagnostic tests and treatment, pejorative remarks, and other forms of structural violence against non-white populations. When we think about it, though, there is no place for explicit bias, racism, or discrimination in our nursing practice when we are called to holistically care for those entrusted to us. In these times, it is not enough for us to say, I am not racist, or I do not discriminate against others. We have to actively work to dismantle these systems that literally make our nation sick, even if it only starts one conversation at a time.